Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in another demonstration video of our soon to be launched WAXscope. And here we have a patient who attended with bilateral, fully occluding, soft but dense, matted earwax. You can see this patient's got quite hairy ear canals and a lot of these hairs are matted into the wax, which can make it a bit more difficult to remove. So what I'm trying to do here is lift this soft wax plug off the floor of the ear canal. Because of all the hairs that's located inferiorly, it's matted in this region quite a lot, and the hairs almost acting like a spider's web. They're capturing this wax plug, and it's very difficult to get a suction grip when you've got so many hairs. Now I'm using our 3.5mm speculae. Now this speculae is one of from one of my earlier batches, and I'm actually, you may see there's a little reflection out around the rim. So we've made a modification to the tooling for this, so that's been sorted, which is great. So the WAXscope is actually ready, guys. I've had a few inquiries. We're just waiting for the finalization of the new app to accompany it. You can use the current app that I use, but I've developed a new app and I just had the latest version today and it's really looking good. So it should be done by the end of the month, and the plan is at the end of the month I'm going to start advertising for the course. So we're looking mid-February, end of February really. So everything's going well. We're just finalizing our entry requirements and a bit more of the course details. So I'm hoping to get all that finalized by the end of the month. So if you are on the mailing list, be prepared to hear from us soon. If you wish to be added to the mailing list, please email info@clearwax.co.uk. So we've got 3 speculae sizes in total. So this is the smallest one, which I'm actually using the most, if truth be told, because it just allows me more maneuverability in the ear. I'm also using the 4.25, which is the standard size. Then we've got a 5mm for large ear canals, and then 5.75 for surgically operated ears that are extremely large. So I've just used a new Rycorette there to release some of this more lateral wax, and you can just see how hairy it is actually, and some of this wax is quite dark on the surface. It's been there for a while. I'm just using the specula to dilate the ear. This is probably the main reason why we've developed the WAXscope to dilate the ear canal. When you use the endoscope, a lot of specialists struggle to straighten the ear canal because our ears are not straight tubes. They are quite bendy and twisty, and obviously to remove wax, especially deeper in the ear, you need to be able to straighten the ear. And with an endoscope, you're using the side of the endoscope itself, so the rod lens, to push the cartilage portion of the ear canal to stretch it open, while simultaneously inserting the instrument into the ear. When you do grasp that technique, for me, there's nothing better than the endoscope. It just provides an unparalleled view, but otherwise I genuinely feel the WAXscope is the next best alternative. I mean, I've used head-worn microscopes before, and this is far superior in every way. With an ENT microscope, they are obviously, I would compare this to an ENT microscope, but a 2D version. An ENT microscope provides with 3D binocular vision. Here it's a 2D view because of viewing off a screen, so you have to gain depth perception using monocular clues. So use the focus really. So when things are in focus, you've got the depth, and when they're out of focus, you're at the incorrect depth. So I'm just at the floor of the ear canal. I think here I actually stood up and I was looking down into the patient's ear canal because the patient was quite tall as well. So the towered above me, so I had to stand up to kind of get the view I wanted inferiorly. This is their left ear, by the way. You'll see once I've removed this plug, they did have some earwax adhered to the eardrum, which we were able to remove quite easily using the WAXscope. And I would previously struggle to done that with head-worn loupes or microscopes to remove wax very deep off the eardrum. So I'm just tugging away. I think I'm going to use some olive oil spray in a moment just to lubricate this wax plug, and so just keratin there that came away around the edge of the wax plug. I'm going to stretch open the ear. I'm going to go a bit deeper with the specula now because we're beginning to remove more of the lateral wax. And you can see one of the view with the instrument, the suction probe, is not obscuring the optical lens. Whenever you've got a speculum like this and you've got a setup like this, if the instrument goes through the centre of the speculum, then it's going to obscure the optics of the lens, the camera lens and the magnifying lenses. So the instrument is inserted into the ear from an angle, which then means the instrument is not obstructing the view, and the instrument is not itself distorted in any way. So I'm really tugging up here. There's quite a lot of resistance here. You may see the floor of the ear canal there. I'm lifting it up and away, but it's lodged deeper in the ear, and it is lodged. This patient's ear canal is quite bendy, so it's lodged in the anterior recess. So the average ear canal is a human ear canal. Or should I say, an adult human ear canal is around 26 millimeters. There are individual differences, of course. And so this wax plug was extended right from the entrance to their eardrum, and where it's deeper into the ear, adjacent to the eardrum, it's lodged in this area called the anterior recess. It's just in front of the eardrum. In the case of the left ear, to the left-hand side, there's a little cave there. A lot of recess, hence the name anterior recess, and the wax plug is trapped there. So when we're pulling this wax plug away, because it's not a straight tube, there's resistance, and whilst I'm removing it, I'm coming away, trying to mimic the curvature of the ear canal. So here I'm curving it to the right and then back to the left. You can see just to the left where the wax plug is, that's the second bend, and the ear canal curves around further to the left. So it's just instilled some medical grade olive oil spray, which helps to lubricate the wax plug, tries to reduce any frictions as I'm pulling this away. Hopefully it's going to glide through. It's on this way, similarly to if you've got a ring stuck on your finger and you apply some soap around the finger to help lubricate it and help the ring come off. Similarly, the oil has the similar effect on the wax plug. I'm slowly coming away. I don't want to lose that suction grip. I've got a good suction grip. You can see around the perimeter there's a lot of dead skin, keratin there. So I'm just going to use the autofocus there. I think I remember I double tapped the screen to get that in focus, and I'm slowly coming away. So why would people purchase the WAXscope? For me, it's if they can't use an endoscope. So if you can use an endoscope, then I think that's going to be your primary method. Although even for me now, I do prefer the WAXscope in certain cases. If I've got a patient who may be a bit nervous or a bit anxious, who not very still, for children's a great example with pediatric patients, because you've got the speculum in the ear, it almost stabilizes the patient's ear. So it gives you more, you feel more secure when you perform the procedure, and so does the patient. Also, you can imagine children seeing an endoscope, which is a 5 centimeter protruding piece of steel, and they can get, although to be honest, only about a centimetre and a half of that goes into the patient's ear canal, but it can be a bit off-putting for them. With the speculi, it's similar to what the doctors examine your ear with at the doctor's surgery. You've got this black hollow funnel-shaped object which attaches to the end of the otoscope, which is the ear lens microscope, which they look inside your ear with. So I do find with those cases in particular, it's very, very useful. So we're looking at the back part. I'm just straightening the ear now. I'm looking at, so with the WAXscope, it is like a microscope, so you don't see the whole eardrum. You see probably a bit more than actually when we first developed it. Normally you only see a quarter of the eardrum at a time, but so this wax looks right on the eardrum, and I'm slowly going to bring it away. There's still a little bit left in the anterior recess. So when you're straightening a patient's ear canal, there's only so much of the ear you can straighten. You can only straighten and manipulate the outer third, which is where we are now. The cartilage portion, the inner 2/3 of the ear canal, is made up of bone, so you can't obviously straighten bone, it's rigid. So I'm just getting that bottom piece in focus, just gliding over with the tip of the fine end. I'm going to be careful because we're on the bony part here. Just going to lift it away. It's a bit stubborn, so I'm going to leave that section, but it's a little bit there, just on the floor, a bit deeper. It's not actually on the eardrum, it's just sitting on the floor, so I just want to see if it comes away. If not, we're going to leave it, but I've got that in focus, so when the instrument comes in focus, you know you're at the correct depth. And I'm just going to lift it away. There we are. Got a nice piece there. So you can see there's a few hairs there. The patient's got quite a hairy ear canal. So with the top of this speculum, you have got a little slit to help with the instrument. So sometimes you can get a few hairs that travel in there. When you've got an instrument, and you can just push those hairs away when you go in. But yeah, patient's got a nice healthy eardrum. That's the umbo, the central region, just getting that in focus. And previously you were seeing the top part of the hammer bone. So same patient, this is their right side once again, very hairy ear canal, just getting the wax in focus near the entrance. So I'm going to, you can see how we're going into the ear, we're going in and we're going to the left, we're stretching and dilating the ear canal. And once more, it's quite matted, it's soft but dense as well, it's quite thick consistency. So I'm just lifting it slowly off the floor, and I'm just coming back a bit with the speculum as well. So we want to get the tip of this plug here. Here it's where it's nestled with all those hairs. So generally speaking, it's older males who have hairy ears. Patients from Asian descent, like myself as well, tend to have hairy ears. As men age, we have a build-up of testosterone in our body, and the hairs in our nose and ears are somewhat desensitized to testosterone until we reach a certain age. And at a certain age, these hairs then become sensitive to testosterone, which then encourages thicker hair growth, and not only thicker growth, but additional hair growth as well. So some of these hairs, as this patient was growing up, they may have been what we call vellus hairs, which are very thin hairs, almost invisible to the eye. They're very thin and they only grow a certain amount, but they can almost turn into what we call terminal hairs. They're similar to the hairs on our scalp. They get really thick and they protrude outwards as well. So you can see how I'm just trying to lift this off the bottom of the ear canal. Actually, here it might have been a bit difficult. Not difficult. I mean, it's for someone who's not used to an endoscope, because to enter this patient's ear with an endoscope, you'd have to put the endoscope into these hairs. There's no other way about it, because you have to stretch this patient's ear using the endoscope. So the view may have not, although it's very hairy here, the view with an endoscope may have been a bit more obscured. With this speculi, the lens of the WAXscope is out of the ear, so it's not being obscured as such. With an endoscope also, the tip might have got quite greasy and oily, because as we go through the hairs with the endoscope tip, it can smear the lens. Just trying to loosen this a little bit. You can give it little wriggle motions, because similar to the plug in the left ear, it's very likely deeper. You can see the definition the WAXscope provides, so you can see these individual hairs very clearly indeed. So here, once again, we're trying to navigate this wax plug around the curvature. So it's just to the right is their second bend, so the ear canal veers off to the right. To the left of this wax plug, just in front, that's the first bend. So as I'm bringing this away, I'm curving initially from to the left and then back round to the right. You can see it's coming slowly forwards now, so I'm going around the bends. So I've just got it past the second bend, and this is the first bend to the left. I've got quite a decent suction grip here, so I'm going to do it really slowly. So you just see the cartilage to the left, that's the first bend. The second bend is obviously not visible because it's behind the wax plug. So I'm curving it around. There we are. It's quite quite a bigger plug than I thought, actually. You'll see at the end, we've got some still images. So I'm just going into the ear to the left first, and then back to the right. That's how you dilate the entrance of the ear canal. So it's quite a stark movement, actually. But first of all, we're looking at the back part of the ear canal. Then we have to rotate the speculum from left to right. That's the patient's eardrum, just getting the top section, the superior part in focus. And then that's the umbo, the central part, just getting that. Because the umbo is slightly withdrawn. It's slightly pulled in. That's the norm of the eardrum. It's not parallel to the entrance. It's slightly perpendicular. So the central section is kind of slightly withdrawn inwards, and the inferior and superior regions go outwards. Well, I hope you enjoyed that video, guys. If you are interested in the WAXscope, please do email info@clearwax.co.uk.